I'd like to introduce today's speaker, Dr. Artellini. As most of you know, Dr. Artellini is the Chief of Division of Pediatric Hospitalist Medicine here at Children's National, and she serves as the Vice Chair of Education for the Medical Center. Dr. Artellini is a graduate of Wayne State University School of Medicine. She did her pediatric residency at Children's Hospital of Michigan and fellowship in academic pediatrics, along with actually a Master in Public Health program at University of Texas San Antonio. She also has graduate certificate in medical education. Dr. Artellini joined Children's in 1992. She's the recipient of multiple awards, such as Ray Healthy Award from Pediatric Academic Society for Most Innovative Educational Research Paper, Golden Apple Awards for Outstanding Teaching Department, many Teaching Excellence Awards, and many more. Dr. Artellini was recently Education Chair at Academic Pediatric Association. She published over 25 original articles, many book chapters, and several invited chapters. She has developed an extensive research portfolio and maintains very active clinical practice. She is an associate professor at Howard University Medical School and professor of pediatrics at George Washington University. And in 2009, she was named Vice Chair of Education here at Children's and probably had headaches ever since. Without further ado, Dr. Artellini.
Thank you. It's a real honor to be here. Thank you, everyone who is in the audience, both here and conferencing in through WebEx. Family-centered rounds is something, as Mark knows, that I'm very passionate about because I think if it's done well, it can be a perfect training opportunity for our residents, students, and fellows, and also bring to the family all the really smart people in the room, both the nurses and the physicians and students, and really help them to understand their disease process and to participate in the child's recovery. This is a picture. I don't know if anyone recognizes this gentleman here. It's one of the first hospitalists, Sir William Osler. And he was an adult as well as a pediatric hospitalist. And this is one of my favorite quotes from him. To study the phenomenon of disease without books is to sail an uncharted sea, while to study books without patients is not to go to sea at all. And I think that this gets at the heart of what we can accomplish through family-centered rounds. Because these days, we have the wonder of technology at our fingertips. But sometimes I find that the cows and other technology gets in the way of interacting and making the most out of the data that we can get from our physical exam skills. And so I think we can get back to the bedside, get back to the basics through family-centered rounds. And so even though we talk about how wonderful things were in the olden days when we went to the bedside and did bedside exams, not everything was perfect. And I'm going to show you a brief video clip in just a minute. And what I would like you to focus on is 3 teaching behaviors that this particular attending does well. And I'll just say up front that this happens to be a surgeon rather than a pediatrician. So take that into account when you're listening. And I think this video demonstrates that although there were a lot of things that were done well in the past, maybe not everything was done perfectly, and we can learn a lot from what we know now about adult learning theory and cognitive psychology to do things better. So could you play the video?
Morning, gentlemen.
Good morning, sir.
Not late, I hope?
Not at all, sir.
Come along, my man. You must pursue me. You must pursue me. I suppose you got another half-dozen boring cholecystectomies today?
Yes, sir.
After last night, I feel like one myself. How about that gastrectomy I did yesterday?
Not so well, sir.
Oh, pity. Great pity. Morning, sister.
Good morning, Sir Lancelot.
Everything ready?
All ready, sir.
Splendid. Now, you just lie still, old fellow. I've just got to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked?
Yes, sir.
See anything?
No, sir.
Very good, carry on. Gently, man, gently, you're not making bread. Don't forget, to be a successful surgeon, you'll need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it?
Yes, sir.
Well, what is it?
A lump.
Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. And where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find?
Subcutaneous fat, sir.
Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man. Blood, you numbskull. You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time?
10 past 10, sir.
So perhaps we don't want to emulate everything that was done in this video, but can we come up with a couple of things that this physician, as the attending physician, did that promoted learning at the bedside? Very good. He got the team to the bedside. Excellent. Okay, he asked questions. Were those learners disengaged? No, they were very engaged. So, and did they learn? So we may not want to use his techniques, but some of the principles that he used, getting the team to the bedside, involving all the learners actively, and teaching a focused physical exam, I think are things that we could learn from him. Perhaps his style and the learning environment could be much improved. So, so the objectives of my talk today are to state principles for effectively combining efficient patient care with teaching at the bedside, describe the utility of a model that we developed here called the ESP model for precepting during and family-centered rounds, state how problem representation can be used to both teach diagnostic reasoning as well as to quickly share a mental model and get everyone on the same page, and to identify ways that we can optimize the roles of the key team players. So what is family-centered rounds and why are we doing it? So the AAP and the Institute of Medicine came out with some policy statements around patient and family-centered care. And basically what they're saying is that they think that rounds that are our traditional work round should be conducted in the patient's room, involving the patient and family in key decisions that are made, and that in doing this in the right way, it will be a valuable learning opportunity for students and residents. And so that's what we're trying to do with family-centered rounds here at Children's. And if I could just see by a show of hands, I know in some ways I'm preaching to the choir, how many people do family-centered rounds here? So it looks like the majority of people. And one thing I want to say up front is I know that one size doesn't fit all, and I don't want family-centered rounds to be a religion. I think that it needs to be flexible, and I think that depending on the setting, some of these principles that I'm going to discuss maybe emphasize a little bit differently, but I think the principles I'm going to talk about in terms of preparing trainees effectively to present and faculty effectively to precept would cross different settings. So in terms of the literature, there haven't been a huge number of studies because family-centered rounds is a pretty recent change in the process of rounding in the hospital. We've been doing it here at Children's for about 5 years, and initially learned about the process as it currently stands from Steve Muthing at Cincinnati Children's. They have an excellent website that depicts videos and gives a primer on conducting family-centered rounds that's very useful. We did a multi-center survey across the nation looking at what are the practices that are currently happening with family-centered rounds, and found that the majority of hospitals, especially academic hospitals like ours, are doing family-centered rounds, you know, the way that it was described in the AAP policy statement in the room. But a significant chunk are still doing it in the hallway or in the conference room. And barriers that were described are those that I think we're familiar with. So concerns about efficiency of time if the patients are dispersed around the hospital. Also concerns about privacy if they're, now we have single patient rooms, so that's really not a barrier anymore. And then I think also the biggest barrier was the fact that both trainees and faculty were unfamiliar with this method, and so they were uneasy talking in front of the family. And we recently did a study here, Prit Bonsali and others in the hospitals division. We did a time motion study using a tablet to record actually what was happening during rounds, and determined that on average it takes about 8 minutes to round on a patient with family-centered rounds. And depending on which study you look at, that may be 2.5 minutes longer than it might take in sit-down rounds. Other people feel like there's really not much difference. But what we found is that there are often barriers to getting into the room, and also it seems like the biggest chunk of time that accounts for that 8 minutes is in the presentation and trying to clarify aspects of the presentation. So it seems to increase efficiency, it'd be good if we could increase the effectiveness of the case presentation. So I'm going to be talking about that. So thanks to Dr. Holbrook and Dr. Stockwell, we have and Elena, we have the 6-hour project. And a really important component of that is how well rounds are conducted. And so in a working group that we had, we came up with these 5 goals for rounds. One is to calibrate and correct a shared mental model, to create a plan for the day, assign and accomplish tasks, plan transitions of care, and then educate everyone in the room. And so today I wanted to focus on the first and the last. And in terms of calibrating and sharing a mental model, I think this is really important when we look at how we learn clinical reasoning, as well as how, if we look at our morbidity and mortality cases and our risk management cases, often it's because people didn't have the same shared mental model. And so I'm a hospitalist, not a brain surgeon, so I use a lot of mnemonics to help to remember things. And so one of the mnemonics that I came up with for how to create the shared mental model or present effectively is IP bears. So the I is for the team, the senior resident, to take responsibility to remember that in the morning everyone greets the family before starting the presentation, and then just ask a couple of simple questions like, how are you and the child doing today? What concerns you the most and why? And I think if we get the parents' concerns out on the table early on, it actually helps us to calibrate how we do the rest of the presentation so that we address their concerns in the presentation and we don't have to double back. So I think that increases parent satisfaction according to the Picker survey and also increases efficiency. And then the next part I'm going to focus on a little bit later, it's P-bear. So I took this from S-bar and then tried to put the bear in somehow. So I'll get back to you about how that works. And then the 2 S's are to solicit input from the other valuable members of the team, the parents, of course, and nursing, and then to share the team's mental model or the plan for the day with all members of the team. And one of the things I'm very excited about is on 7 East, they have now an I-5 project for nursing, so that when we finish discussing the patient, the nurse summarizes her understanding of the plan for the day in a way that the families can understand. I think it's fantastic. So what is the patient and family's perspective on this? So we're putting a lot of effort forth, and if the families don't really value it, then it's probably not worth it. Well, there have been, again, not a lot of studies, but the studies that have been done, over overwhelmingly are supportive. Families value rounds when they're done in a family-centered way because it involves them in the key decision-making. It helps from the team's perspective to correct misunderstandings in the communication of handoffs, maybe from the emergency department or other settings. And it really helps the nursing staff and other members of the team to communicate well and everyone to be on the same page. Spanish-speaking families in particular value the fact that an interpreter is present on rounds, and that's something that we make a big effort to do here at Children's. In terms of educating yourself, I am a big fan of just-in-time learning. I think from adult learning theory, learning in the context of which you're going to apply the information helps the information to be retained much better and to be much better understood. So if we're at the bedside of a patient who has an unusual genetic syndrome, often it's one that I haven't seen before, and with my trusty iPad or iPhone, I will look that up in the presence of the family so that I have a better understanding of what's going on with the child. And sometimes we can actually look up information that impacts the care of the patient that's in front of us in real time. And I also think a key thing that trainees can learn from also is observing and participating in a focus part of the physical exam. I have a digital stethoscope that has a port where up to 4 people can listen at the same time. So all we have to do is sneak the stethoscope in with a child that, you know, if it's a cooperative child, and everyone can be engaged. I think teaching the team about the patient's diagnosis also teaches the family and vice versa. In terms of, okay, so the parents, of course, and the patient are the most important constituent, but trainees are a very close second. You know, our mission here is, you know, to educate the future generation of pediatric care providers, and we want to be sure that we're not compromising that. And so the studies that have been done looking at medical students and residents, and we have a study that we submitted to pediatrics of a focus group that was done both here and at Dallas Children's. The findings from these studies are that because for medical students, family-centered rounds isn't done on other disciplines, there's a pretty steep learning curve in a sense of feeling uncertain about how to do that. And so here at Children's, we try to build in a workshop at the beginning of their inpatient rotation and have opportunities for deliberate practice so they feel more comfortable at the bedside. Residents overwhelmingly, and I'll just ask here, if you could raise your hand if you think family-centered rounds is a good learning opportunity if done well, if there are any residents in the audience. Okay. All right. So the few residents that are here are raising their hands. Good. But I think that's a big if. And so I think there's a big component of how the faculty conducts rounds, and the residents say that there's a lot of individual variation which impacts how well they're able to learn from family-centered rounds. So that's an area that we want to work on and that I'm going to talk about. So learning during family-centered rounds, I've done grand rounds at other institutions and visited other institutions across the country and also collaborated with others doing workshops. And so the lessons that I've learned, and also from all of you here in the audience, are that efficient case presentations are like #1. And so this is something that we really have to rely on our students and interns to do a good job of. The other thing is I'm going to repeat, don't repeat. Because if you listen to presentations on rounds, you often hear a summary statement that occurs over and over again in the presentation. And that's often said to be the assessment or the analysis, but really it's just a summary statement. It doesn't usually reflect any thought process. So we're going to try to get away from that. And the other thing is, if there are multiple members of the team, everybody doesn't have to talk every day on rounds. So if the student does a fantastic job and there's really nothing much to add, You don't have to say, I agree with blah, 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 blah. And then the senior says, I agree with, repeats, and then the attending repeats. We can just have one person state that. So less is more. And then, as I mentioned, see and examine the patient, and deliberately multitasking, as I mentioned. So trying to learn while you're in the room with the patient in a respectful way. And I'll show you as the attending how you can be diagnosing the patient while you're diagnosing the learner. So in terms of efficient case presentations, you know, the wonderful thing about technology and the electronic medical record is that we have all the data at our fingertips. It used to be the job of the medical student was to go and gather up all the data, the I's and O's, call the lab, so we have everything together for rounds. Now they're actually freed up from that responsibility, and so we want to give them the opportunity to think about the data, not just report it, but think about it, and to select which information is most important to make decisions about the patient in the bed today. We don't want all the information, we just want the information that we need to make decisions, and we want to focus on thinking and not as much on the raw data. So in order to do that, we came up with this P-Bear process. So it's taking the traditional presentation and just tweaking it a little bit. We're not completely throwing it out the window. But instead of the chief complaint, basically what we're doing is we're taking that summary statement, the assessment that usually comes after all the information has been given, the history, physical, and labs, and then there's a summary statement, flipping that to the beginning. So it's an assessment-driven presentation. We don't want the diagnosis there, but we want you to say what the defining features of the patient are so that as the attending, I can quickly get a sense of where you're going with this presentation and then listen more carefully to the key background evidence. And the oral presentation should be a synopsis or a synthesis of what's in the written presentation. It should not be reading off the computer. And then in terms of the analysis, once you've presented the key data, if it's a new patient, then I'd like you to tell me what you think is the most likely diagnosis and an alternative one that you considered, and what are the distinguishing factors between those two alternatives so we don't come to premature closure. If it's an established patient, we just need to know, is the patient getting better? If they're getting better, what do we need to do to get them home? And then in terms of recommendation, one of the things that we think is that this is a great role for the intern in terms of presenting the plan versus having the medical student focus on the first part of things. And it's fine to say if you're not sure about an issue, and also to identify what you want to read about. So in terms of the role of the faculty, we want to have effective models for precepting in a busy clinical setting. And there are a couple of models that are out there. The one I'm going to describe is one that we looked at in our outpatient setting called the 8-step preceptor ESP model. And in the recent journal, in the recent pediatrics article, there's another model called SNAPS that you can read about that is another way to encourage clinical reasoning in the process of the presentation. So this deliberate multitasking on the part of the attending requires some skill and practice. And I know there are many attendings in the audience that I've observed do this very well, that are models for how to do this in different disciplines. So the first part for the attending is to diagnose the patient, of course. So to actively listen and to have the opportunity to clarify information as the presentation is going on, determine the concerns, to do a focused physical exam. And then as you're listening to the presentation, also be listening to diagnose the learner. The learner can help a whole lot with this if you can commit to a thought process so we have something to work with. And then we can try to understand your thought process better by asking you a few questions. The senior resident's job is the team manager, and they should, in some higher level settings like the ICU, this would obviously be the role of the fellow rather than the senior resident. But to determine the plan, communicate the plan, make sure that people are entering orders, and make sure that we're focusing on the details of patient care. And then as the attending, my job is really to manage the learner, to correct misperceptions or errors, to reinforce if something was interpreted correctly, to highlight that so that people don't miss salient teaching points. And then to help identify, help the learner to identify their own learning objectives. But this is not the time for me to do a mini didactic on bronchiolitis. That should be reserved for a classroom setting, attending rounds. As the attending, I need to be able to triage what are important teaching points and just really pick one. Even though I'd like to stay there all day in the room and discuss multiple teaching points, to be efficient, I really need to focus on one of those. And so again, a mnemonic that I came up with to remember these different steps is SLIGHTED. So S is a safe learning environment. L is to know the level of your learner so that you're teaching to their gaps. And then I think that it's fine after the history or the physical for the person who's presenting to pause and ask if there are any questions rather than waiting all the way to the end, and then again we have to double back. It's really important that the learners commit to a thought process and describe that thought process. And then as the attending, as I mentioned, I can highlight what was correct thinking, or I can think out loud if the team didn't quite get it right. Target the teaching point, correct errors in thinking, and then direct the learner to identify their own learning objectives. So in terms of ground rules, I think ground rule number one is everybody in the room is thinking. The students should represent the problem, give the key background evidence in the analysis. The intern, I know this is kind of radical, but we've tried it when I've been on rounds, and it's actually, I think, worked pretty well, where we have the intern give the plan, because I think this engages the intern in rounds, and the medical student's job is really to learn pediatric differential diagnosis, not necessarily to learn how to manage the complexity of patients that we have here. The senior resident solicits the concerns, as I mentioned, and then the attending is really more of the coach for the learners. And in my mind, if the senior resident does everything well, I need to say very little. And that's being effective in my role as the attending. And in terms of targeting teaching, I want to try to address a gap in one of these areas, either clinical reasoning, interpreting the physical exam, or communication skill. And I think that focusing on clinical reasoning is really a key aspect of what we can do during family-centered rounds. So focusing on efficient case presentations. I have to say up front, I love medical students. This is one of the fourth-year medical students when she was a little bit younger. But I think we would all kind of also, reading this statement, probably say that we've experienced this. So we've developed a feedback tool that we use for student case presentations. And we actually have these live scribe pens that we can use to record presentations in the room on this paper and give the students real-time feedback. And we think that using this deliberate practice will help them to improve their presentations. So what I'd like you to do is just using that handout that I just showed you, view this video of this student and see what kind of feedback would you give to this student and how would you use the tool. You want to play the video?
2-year-old female I saw in the emergency room with likely pneumonia. She had 1 day of fever and 5 days of cough. The chest X-ray from the ER showed a normal heart with an opacity in the left lung. Her mom said that she'd vomited twice and that she was really looking sicker than normal, but there was no history of travel outside the country. Past medical history is significant for normal spontaneous vaginal delivery without complication. She went home from the hospital with her mom after 3 days. Mom said she wasn't aware of her GBS status at the time. Her past medical history is significant for 1 prior ear infection. She's not otherwise been hospitalized, no operations, no known drug allergies. She did take 1 teaspoon of Pediacare 3 times before admission. She'd also been taking 1 teaspoon of Tylenol just for the fevers. The fevers have ranged from 100 degrees Fahrenheit to 104. Developmentally, she's walking and running. She can combine 2-word sentences. Review of systems is significant for, there were no eye findings. She has been congested, not really eating well, Mom says. She's unable to tell if she's really bringing anything up or if it's a dry cough. And she has had more concentrated urine, but doesn't seem to be urinating as often as she did. Family history is significant for sugar, and just about everyone has high blood pressure in the family. She lives at home with her mom and her 5-year-old brother, and they live in D.C. Physical exam, extraocular muscles were intact. She had good red reflexes bilaterally. I couldn't really assess her ears. I didn't have an otoscope. There was some mucus in the nose. Oropharynx showed no erythema. Neck was soft with full range of motion. Lungs, she had bronchi bilaterally, but there was no particular wheeze. Cardiovascular exam, there was a 2 out of 6 systolic ejection murmur, and the abdomen was soft, non-tender, with some hyperactive bowel sounds. For labs, her white blood count was 22. The differential was 75 segs, 12 lymphs, 10 bands, 2 monos, and 1 eosinophil. Her hemoglobin was 12. Her crit was 36.5. Platelets were 276. Sodium was 149, potassium 4, chloride 110, and CO2 was 22, BUN 20, and creatinine 0.5. Glucose was 110. She had a negative RSV. And blood culture is still pending, and the urinalysis showed a specific gravity of 1.035, pH 5.5, negative leukocytes, heme, urobilinogen, glucose. She was 1+ positive for ketones, and it said 0 to 2 red blood cells, 0 to 2 white blood cells. Chest X-ray, as I mentioned before, showed the normal heart. There was the left-sided opacity and a possible pleural effusion. For my assessment, I think that she probably has a pneumonia. We can admit her, and we decided to give IV ceftriaxone, Q8 hours, and Tylenol as needed for fever. We'll give some oxygen as needed, and I guess keep her on IV fluids. And we asked for strict isonode.
So, how many of you feel that this is an average student presentation? Okay. How many above average? Below average? Okay. I'd like to thank Craig for sneaking behind rounds one day and videoing this medical student so we could show it. No, I'm just kidding. We had the student act out the part. So we show this at the beginning of the inpatient rotation to help the students to calibrate what we're looking for in terms of the presentation. And using the form, pretend that they would give feedback to this particular student. So we won't take time now to do that, but if you were listening to this, for me, instead of getting angrier and angrier during the presentation, I can do something constructive, which is to take my magic pen and to start recording what feedback I would give to help the student do a better job next time. And so what we're really focusing on is changing from reporting the history. This is from a New England Journal article by Judith Bowen that talks about how to teach clinical reasoning. So this is an excellent example of, in adult medicine, reporting the history versus presenting a synthesized history. And I think this is when we say this student has a hard time, or intern, focusing on the forest for the trees. We are looking for that synthesis part. And I think that's something that we really haven't done a great job of teaching in medical school or necessarily during residency. There's this rhyme mnemonic that Lou Pangaro came up with in terms of how to assess where trainees are in terms of their ability to care for patients. And the lowest level is the reporter. And we'd like our students and residents for sure to move from the reporter to the interpreter level for the general types of patients, recognizing that if you were in a setting like the ICU, you might be focused on the reporter level if you didn't have a lot of background in that area. And then the manager is the senior resident, the educator is either the senior resident, the fellow, or the attending, depending on the patient. So the question is, how do you teach this? Okay? We all know it when we see it, and we know how we do it, but it's hard to figure out how do you help a student or a resident who's really struggling to get there. And this goes back to theories about diagnostic reasoning. And basically, there's the novice, which is always functioning at this analytical, hypothetical, deductive strategy, where you're using a lot of mental energy to try to figure out how does the pathophysiology, et cetera, work. When you become more experienced, you move down to using rules. You have enough experience that you start using heuristics, and then when you are in your domain as an expert, you're functioning in system one, so it's almost on autopilot. And so you can see how if the students are up here and you're down here, and you walk into the room and you know exactly what's going on, you have to deliberately walk back and go through your thought process for how you got there, or the student just doesn't get it. And there's a great book by Malcolm Gladwell in the lay press called Blink that talks about this. Again, this is a great article by Judith Bowen that talks about basically what I'm talking about today, which is strategies for promoting clinical reasoning. So this theory of problem representation that I'm going to talk about came from studying students in other disciplines, and started off with studying middle school students in algebra, looking at which students did the best. And I took this when I was trying to help my son with his algebra from his math book. And so I'll just give you a second to see if you can figure it out. What I'm looking for is to see if anybody takes out their pen and starts making a Venn diagram or writing an algebraic equation. So I realize it's early in the morning and algebra is probably not your favorite subject. So I will move on then, because well, we're not going to go into solving this problem right now, George. I can discuss that with you afterwards. But the point of it is that our patient histories and physicals are a lot like these word problems. And the students who did best in algebra were able to pick out what are the key variables here and then represent them in an algebraic equation, and rather than just like looking at it and trying to solve the problem without going through that step. So that's what this idea of problem representation. And as a hospitalist, I really like, because we have a lot of patients that come in as with a particular label that turn out to really be diagnostic unknowns. And I really like trying to figure that out and trying to teach other people how to do that, to follow the clues. So the clues are the defining features. And then the next piece is using adjectives to describe how you're thinking about those defining features, putting them all together into a run-on sentence called the problem representation, which is your mental model. So here's a family pet that we have. He's now deceased. But if I was trying to tell you about my pet, you don't have a picture of him in front of you like you do right now. I could say he's a furry, four-legged, friendly, black and white family pet. So you might get this picture in mind, but you also might be thinking of this other pet that I have in my house, which is a black and white cat, or maybe a different kind of a dog. So what I'm doing is presenting a mental model with the problem representation, but then I'm going to give you more details. So hopefully at the end, I can describe the discriminating features between these two pets, and you would be able to understand my rationale and either agree with it or disagree with it. So, so basically, defining features, adjectives, which are called semantic qualifiers, equals problem representation. So the defining features are basically what we learned at the very beginning of physical diagnosis in terms of the chief complaint. What are the defining features? In pediatrics, age is always a defining feature because it helps you going down your differential diagnosis tree. Often duration, the quality of the complaint is a defining feature. And basically what we're teaching people are these illness scripts. In particular, complaints have different illness scripts. For example, if you look at a patient with fever and rash, Rocky Mountain spotted fever versus scarlet fever. Wouldn't it be great if you had two patients in rooms next to each other that each portrayed these two different diagnoses? Then you could say, what are the defining features here? Age, the primary lesion, what the distribution is, how did it spread, and then associated systemic findings. And you could, there's nothing more powerful in terms of teaching clinical diagnosis than seeing a patient and having somebody link the defining and discriminating features for you. You'll never forget it. So what is meant by these adjectives and why are they important? They're important because those are like the code for how you are processing thinking about these defining features. And it's best if you pick an adjective that has a defined opposite, so acute versus chronic, because it's talking about how you're going down your diagnostic tree. And the purpose of adjectives actually cements these cognitive pathways in your brain. So the next time you see a patient that has a similar constellation of findings, you're much better able to recall them. And what I'm trying to do is to speed up that process from novice to expert. You know, people talk about it taking 10,000 hours to get from novice to expert. Well, I'd like to move that up, and I think this is potentially a way to try to do that. So here's an example of problem representation. We're in the room looking at this patient. The typical chief complaint is this. Here's the history. Here's the physical. And you might just jump to say, well, I think we should start the IVIG, you know, and the aspirin. And as even for early students in pediatrics, they get this illness script or pattern recognition for this patient with Kawasaki's disease. But if I showed this to a group of internists, they would be going through that analytical, hypothetical, deductive because they're not used to seeing this pattern of findings. And so what I'd like to do is really encourage people to take that next step instead of going directly from the word problem to the answer, is actually representing the problem. So, and the adjectives are here in purple. So this is, you know, kind of maybe a little bit of a long problem representation. And there's no one right problem representation, but the idea is you take your summary statement and put adjectives in front of what you think the defining features are. Why is this important? They studied doctors who get sued. I was on a task force with the National Board of Medical Examiners, and they found that doctors who use more semantic qualifiers, when they're not in their area of expertise, are much less likely to get sued. So how do you teach this? Well, as I've talked about, we have workshops for our medical students. We have them take a highlighter and highlight the defining features. But I think they also need opportunities for deliberate practice. So we've given them some sample cases and had them practice that. But I think there's no substitute for getting regular feedback during rounds. And then with recording, not recording the patient's name, but recording the rest of the presentation, we can actually save that and feed it back through a sound file to the students so they can listen to themselves. This is a workshop that we do with the students at the beginning. Another environment to practice this is during morning report. And I think our morning report here actually is done quite well. Sometimes in morning report or in case conference, it can be actually too safe, where you don't really get to what the person's thought process is. So here's an example. An 11-month-old was witnessed to cry and then turned blue when a toy was removed from his possession. He passed out and was noted to shake for a few minutes. The grandfather performed CPR. So I'm sure George Cohen knows exactly what the diagnosis to this is. But in the typical fashion, sometimes we'll go through, okay, let's go through the whole laundry list of everything that we know about this patient. Then we talk about, you know, what test might you want to order, and then go through a laundry list differential, which is everything from cardiac something to Q fever. And then, you know, what test do we want to get, okay? And so what we're promoting really is a dispersed model of knowledge rather than synthesis. So really what we want to focus on is when we're hearing about a patient, we really only think about one or two, at the most 3 diagnoses at the same time. So breath holding spell, and then we often think of like, what would be a bad thing if we missed it, and perhaps seizures. So, you know, then you spend your time comparing and contrasting what goes along with this patient for these 2 diagnoses. And this is called co-selection. So when you first hear about the initial presentation, you start to think, 2 or 3 hypotheses in your mind. The problem representation helps you to do that. And then in the analysis, you highlight the discriminating features. So getting back to the family pet, in the analysis part of the P-Bear, we'd want to focus on what differentiates the dog from the cat. And from a trainee perspective, if you're at the beginning of training, you should be able to differentiate the broad differences between a dog and a cat. But it might take a more nuanced, advanced learner to be able to say why this is a husky and not this sheep-type dog. So in terms of the defining and discriminating features, our example of Rocky Mountain spotted fever, the blue would be what could be presented in the initial one-liner, and then the red would be the focus of what's presented in the analysis. So promoting this during rounds, we want to focus on using a constructivist approach, which means that you, knowing the level of your learner, don't just ask a whole lot of what questions, like what am I thinking, but we expect that the learner is going to come to rounds with some background knowledge so we can use that to ask why questions and build on that. And again, our mnemonic is don't be slighted. And so one of the big questions is how do we help make sure that faculty are kind of all on the same page with how we're doing this. And I'm certainly not saying that there is one absolutely right way to do it, but I think if we can kind of use these different principles, there's certainly opportunity for individual variation in style. But I'd like to get feedback maybe after grand rounds for how people feel like it would be most effective. We've actually produced some videos with the help of the National Naval Medical Center. They donated almost a week's worth of video production time in a professional studio. So we produced a video for families that we're going to have on the Get Well Network, because one of the concerns of families is that, on the first day, they don't really get what's happening, and they don't really understand who the different people are in the room. So this video helps to explain that. But we also have a couple of videos for attendings and residents about, kind of ideal behaviors and not so ideal behaviors on the first day. And then we have a video for the day before discharge to demonstrate how what you talk about on a subsequent day is truncated compared to what you talk about on the first day. This is a feedback tool that we are going to start encouraging trainees and others to use to give feedback to attendings and senior residents about their precepting during rounds. And then I'd like to conclude by just showing a brief video clip from the DVD that we produced. And I'm just going to say up front, this is the dysfunctional or bad family-centered rounds. And we're going to get the final videos in the next couple of weeks, and we'll be posting those on the internet. And we'll let you know when those are posted so that you can hopefully view them and glean some of the lessons that we've learned by trial and error. So do you want to play the video, Philip?
Good morning, Ms. Johnson. This is the team that's going to be taking care of Jesse while you're here in the hospital. I'm going to let them know about what's been going on and brings Jesse into the hospital. If you could save all your questions, and if I make any mistakes or leave something out, if you could just let us know at the end. Is that okay?
Sure, that's fine.
This is Jesse Johnson, our 7-year-old male admitted with neck swelling and fever. Jesse was prescribed clindamycin 5 days ago by Dr. Kirk, his pediatrician, when he first complained of right neck swelling and fever. He was taking clindamycin 3 times a day until yesterday, when he developed allergic symptoms of rash, hand and feet swelling, and red eyes.
Red eyes. What do you mean by red eyes? Was there discharge? Was there periorbital edema or erythema? Give me a little more than just red eyes.
I don't think there was discharge. but the red eyes did improve since he stopped the clindamycin and started taking Benadryl yesterday. But the rash and swelling have not. His fever has ranged from 101 to 104 and has been responding only to Motrin. The neck swelling is bigger, and all he wants to do is lay on the couch, watch TV, or sleep. He's been drinking a little less, but Mom says that he is urinating a normal amount. He does need to be carried to the bathroom because his feet are so swollen and hurt him. On exam, Jesse has been ill-appearing and prefers to sleep, but he will wake up to answer questions appropriately. Temperature range from 36 to 40, respiratory rate from 14 to 32, heart rate from 88 to 120, and blood pressure from 100 to 110 over 62 to 68. His IV is running at 65 cc's per hour. Urine output is 800 cc's. Head is normal cephalic and atraumatic.
Okay, we just need the pertinent.
Okay. His bulbar conjunctiva are still a little red. Pupils are equally round reactive. His red reflex was positive bilaterally. His lips are cracked and his tongue is red, but tonsils are normal. Tympanic membranes are pink, but with a normal light reflex. He has a 4 by 6 centimeter firm, tender right anterior cervical swelling, limiting his ability to turn his neck to the right. No axillary or inguinal adenopathy. His chest is clear auscultation, heart regular rate and rhythm, normal S1 and S2, no murmur. His abdomen is soft with normal bowel sounds. You can see his red rash. The dorsal aspect of his hands and feet, as well as his fingers and toes, are swollen, and he does not want to stand. He did have a CBC with a high hemoglobin of 8.9. His white count is 18,000 with 75 segs, 8% bands, 2% EOs, and 15% lymph. ESR was 110, and blood culture is still pending.
Okay, what about, I hope they got LFTs and a UA? Or I hope you got them?
LFTs and a UA weren't done. The only thing done in the ED was blood culture, CBC, and an ESR.
The LFTs and the UA would have been helpful. Who saw him in the ED anyway? Just never mind. Go on.
Dr. Smith, why don't you finish up your assessment and plan?
My assessment is that Jesse most likely has a Clinda-resistant MRSA and may have an abscess. He also seems to have a clindamycin allergy. We've started vancomycin on admission, and he has NPO for next CT.
Okay, can we just stop for a minute? Dr. Post, what is all this vancomycin, clindamycin allergy stuff? What do you think is going on, Dr. Post? Medical students. This is a clear case of Kawasaki's disease. Okay? Let's stop this with the allergic reaction, vancomycin, mumbo jumbo, and let's get to what the diagnosis is here. It's Kawasaki's disease. Do you agree?
Yes.
What do you think? Yeah.
Kawasaki disease? I've never heard of that before. Now I'm starting to get confused. Can you talk to Jesse's pediatrician, Dr. Kirk, about this?
I'm sure Dr. Kirk has heard of Kawasaki's disease. We'll get the infectious disease doctors and the cardiologists to come, and if they agree with us, then we'll start him on treatment right away, okay? We're going to start him on some IVIG and some aspirin. You've heard of aspirin? Okay. So this is family-centered rounds gone really wrong, and I'm sure you could identify a lot of things that we would not want to do. We do have good examples, and we'll ask you to log on. We'll let you know when those are available and log on to the website to view those. So thank you very much, and if anybody has any questions.
We have 1 minute for questions, if anybody have any questions. Okay, there's a question. Do you think you could come to microphone? Okay, there you go. Here's a microphone. Oh, I'm sorry, we had 2 questions.
Mary, I enjoyed your talk enormously. I just wanted to mention, when we are on rounds and one of my young colleagues are looking on their iPhone to search for the differential diagnosis, I always get the impression that they're checking their email. So the parents may have the same feeling as well. But majority of the time, they're actually helping me out and they're looking for diagnosis. Another thing is that when I do that, I need a magnifying glass to read my iPhone, so that doesn't work for me. Why can't we do it on our cows that has access to internet so everyone knows that we are doing the right thing?
Yeah, I mean, you certainly can. Whatever, it's just that there's only so many cows that we can fit in a room, and so, you know, I think that I agree with you. And one of the things that we're putting in the video for families, and we're relying on the professionalism of our staff, is that they won't be checking emails. They'll be looking up information about the parent, and that's what we're telling the parents we're doing. But I agree with you.
Thank you.
Thank you.